I don't think anybody wants to do that.
Welcome, everybody.
I'll with you for a week or something.
Oh, yeah, let's get just a couple folks on mute so we can hear and get that started. Excellent. Welcome, everybody. My name is Jen Anderson. I am the CHAMPS Clinical Quality Improvement Director. I'm your moderator for today's event. Community Health Association of Mountain Plains States, or CHAMPS, is the Region 8 Primary Care Association. We provide technical assistance to community health centers in Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. And I am very happy to welcome you to the fourth session of our Region 8 Maternal Health Summit, Strengthening Foundation, Innovations in OB Care and Workforce Development. We have a wide variety of participants from agencies all across the maternal health ecosystem with us today. And because of that, I'm going to ask that each one of you please take a moment to rename yourself. We would love to have your name, your organization, and your state. To do that, you can just hover over your picture and there's a little ellipses in the top right-hand corner. Click on that and you should be given the option to rename. If you're having any trouble with that whatsoever, please reach out to Haley Donahue, label as Tech Help in the chat, and she can get you renamed today. So as in our previous sessions, your feedback and contributions are a really important part of the summit. And so we hope you'll add your questions and contributions to our discussion today in the chat, or feel free to raise your hand and we'd love to hear from you and get your perspective. This session is being recorded for future reference. Also, if you need technical assistance at any time during this event, please message Haley as Tech Help, and she'll be happy to help you out. If you are able, we would love to have the people on camera during the discussion portion to create a more natural setting, but we do understand if you're not always able to do so. So, Dr. Sharon Talboys, Associate Professor in the Division of Public Health at the University of Utah, will serve as the facilitator for our discussion today. And we'll be joined by Dr. Carl Whitaker, Family Medicine Obstetrics Fellowship Director at CHC Inc. for the University of Utah, Dr. Samantha Greenberg, the Kalispell Site Director at Greater Valley Health Center for the Family Medicine Residency of Western Montana, and Tanya Beatty, Midwifery Lead at Family Healthcare in North Dakota. Dr. Talboys will introduce our speakers a little bit more today, but you can also read their full bios in today's handouts. And so if you haven't done so already, you can download the handouts for this session via the chat section. And this document also includes the slide deck for future reference. Finally, I'll add that the views and opinions expressed throughout the summit are solely those of our speakers and panelists based on their individual expertise and do not necessarily reflect the views of CHAMPS. And with that, I would love to turn it over to Dr. Talboys to get us started today.
Great, thank you, Jen. Morning or afternoon, depending where you're joining from today. We're excited to be talking about innovations in OB care and workforce development, particularly with a primary care lens. This is one of the main topics that came out of the CHAMPS Commission Maternal Health Environmental Scan. If you're in any of our prior sessions, you'll know that there's a report out with our preliminary findings, and we've had discussions throughout the morning about what to do with those findings. And so we'll be using this session and your questions and what we learned today to incorporate into the final report. Let me first introduce, it's my great pleasure to introduce you to our panelists from across 3 states. First, we'll hear from Dr. Carl Whitaker, joining us from Community Health Centers, Inc. here in Salt Lake City, Utah. He's been with them for 18 years and is a strong leader in resident education. He's also a PI in a community prevention and maternal health grant through HRSA. And at the CHC, he cares for an urban and underserved population and does a lot of teaching with medical students, PAs, and others. He has so much to share with us about innovations and that this larger urban community health center network is a large provider of labor and delivery. So we have lots to learn from Dr. Whitaker. Second, we'll hear from Dr. Samantha Greenberg. Dr. Greenberg moved to Montana from the Northeast, like New Jersey and Rhode Island, and joined the faculty of Family Medicine Residency in Western Montana. She's based out of Rural Training Site in Kalispell, Montana, where she's currently the residency director. She practices full spectrum family medicine, including surgical obstetrics with an emphasis on reproductive justice and equity, as well as dyad care in the intersection of perinatal pediatric care in areas including parental mental health and breastfeeding medicine. I'm also pleased to introduce our third panelist from North Dakota, Tanya Beatty. She's a nurse midwife and provides care during pregnancy, childbirth, and after delivery. and for women across the lifespan. She speaks Spanish fluently and spent a semester studying in Antigua, Guatemala. She obtained her master's in nursing, um, master's of science in nursing, and is a certified nurse midwife, and is board certified. She completed the Spinning Babies workshop and is a member of the American College of Nurse Midwives. Tanya, thank you for joining us today, and to all our panelists. First, I'm gonna turn it over, or not turn it over quite yet. I just want to give two main areas with this topic that came out of the environmental scan, two major themes. One is about models of care, with some of these hot topics around labor delivery, maintaining a care continuum, mental health and substance use disorder, integrated care models, and linking to resources, community resources. There's a quote here shared by one of the participants that we were not able to find an OBGYN partner that would provide C-section backup for our family medicine doc who was actively doing deliveries at another facility. So sadly, we had to phase out our prenatal services. So some of these models of care break down sometimes, and we see a lot of overlap and spillover into workforce issues, which as you can imagine, a huge concern is maternity deserts, simply not having enough providers and in the right places. We'll hear a lot today about recruitment, retention, residency trainings, leveraging midwives, and other professionals like doulas, community health workers, to augment services. So just wanted to point out that if you're interested in that report, it's on the website and with your conference materials, and probably being put in the chat if you want to learn more about that. But without any further ado, let's hear from our panelists. First, we'll be talking with Dr. Whitaker, who I'm sure will be telling us about the primary care distribution and or lack thereof, especially in Utah, where Utah has the lowest ratio in the nation of primary care providers. And here's just a fun fact slide about the distribution of OBGYNs. This is a national map. A few things about our region. South Dakota and Montana fare better than the national average with the number of OBs per capita. Utah's at about the national average, and Montana's a little bit below the national average with no data reported for Wyoming and North Dakota. So I could go on, but I'd rather hear from the source and welcome our first panelist. So Dr. Whitaker.
Yeah, thank you for inviting me to talk today. And I don't think I'm necessarily the most qualified. I see some names in here that have been doing this kind of work, like Dr. Rifleman and Dr. Horwood, for years longer than I have. But if they feel like they want to chime in and update myself on anything that I may misstate, but I appreciate the offer to talk about the CHC and particularly about our training program. So. Just recently, well, just from background, we were founded in 1978. We have 7 clinics, as you can see, across Utah. And you can kind of read there for yourself what we're all trying to achieve, which I think is probably similar to many of you. Kind of look at the payer mix. And we just have a long tradition, long before me, with teaching. We've had a fellowship now for 25 years. Our first fellows were in 1999. And one of them still works for us, and one of them loved it so much they went back and did an OBGYN residency on top of their family medicine residency, and is still a great partner with us at the University of Utah. You can kind of see some of here. We deliver anywhere between 14 and 1,500 babies annually. We take care of all all high-risk patients, diabetes, high blood pressure, anything you can imagine. We do a lot of antenatal testing in our clinics. We have a great working relationship with our maternal fetal medicine doctors here in Salt Lake City, both at the University of Utah and Intermountain Health. And that's a big, I know that's a big barrier sometimes with MFM or OB in certain areas, and we've been really blessed to have great partners that have made this a collaborative effort, if you will, for us to be able to do training and to take care of the patients we take care of. You can go to the next slide. This is some information about Utah, specifically primary care. You can kind of see there that we need new PCPs, 124 a year, which is double the current workforce. As you already saw, we're down here in Utah, trying to produce more graduates every year. You can see there now with the addition of our family medicine residency, we would be up to 30 a year is the hope. And the retention is about 50% in state. Next slide. If you go back one slide, these are just so this is our first class. We just started. We're a teaching health center residency program. Just got funded. Our program director is Dr. Frank Powers. If you want more information about this, he's the guy to talk to. He's done an incredible job at getting this in place. A lot of people told him that it was impossible, and that's all he usually needs to hear to make something happen. And so we're going to be a 4-4-4 program. We've just finished our interviews for the second year and are looking forward to adding a second class, but we're very excited about that. It's not necessarily anything new that we do at the at the CHCs, but it's the first time we've had our own residency within our own clinic. And we're looking forward to teaching teaching new family medicine primary care doctors who do what we do and who want to do what we do. And they're dedicated to mission. There's a Spanish language training program within our curriculum. Um, we do a longitudinal track more than the traditional block track. And we've got shared didactics with the University of Utah, a street medicine curriculum, some really exciting things that are going on. And these four have ventured with us to be the starters of a new residency. So that's been really fantastic. Next slide. And then this just gives some information about the Family Medicine OB Fellowship. Again, founded in 1999 by Dr. Steve Ratcliffe, for those of you that may remember that name. And Dr. Horwood was the fellowship director when I was a fellow. And then I've been the fellowship director for about the past 16 years. It developed as a program of coordination between the Department of Family Medicine at the University of Utah and the CHC and the Department of OBGYN. Like I said, without that partnership and without that collaborative effort, it would be more of a struggle for us for sure. The fellows split their time between fellow activities where they are on labor and delivery services at LDS Hospital, Intermountain Hospital, and the University of Utah, and then spend half their time as an attending at the CHCs. And then recently in 2021, we were awarded a HRSA grant that allowed us to expand from 2 fellows to 4 fellows annually. And we're currently in the last year. And as many of you know that do grants, this is where we try to figure out how to continue that funding going forward. But we've got some good partners, and we're hopeful that we can keep that training going forward. Um, and I think you've already kind of alluded to the fact that I think family medicine is the answer to a lot of this need. As one of my partners, he calls us the Swiss Army knife of medicine, right? We can kind of pivot from one thing to the next, and it's hard to recruit OBGYNs to go somewhere where low volume is going to happen. But family medicine with obstetric training, you have people who can do C-sections, who can help back up other family medicine doctors, midwives, other people who are practicing at delivering. And I really think that they're who we need. And so the idea is to developing this pipeline when we train these people. And most of our graduates, at least in the last 5 years, have gone to critical access hospitals in rural areas, or underserved FQHCs, in urban settings. And so I feel like we're helping with that pipeline. We sure would love to keep more of them in Utah. There seems to be a draw other places. And so I think working actively with our partners here in the state of Utah and in the Champs region to hopefully keep and retain the people that we train to help with the needs that we have. That's all that I have to say for right now.
Oh, Sharon, you are on mute.
My apologies. Thank you, Dr. Whitaker. I want to encourage you all to put questions in the chat. We'll monitor those and and cover those as they come up, but we're going to move on to our next panelist. I wanted to share this one. You were talking about rural and residencies. So it's a really important area that we grow our residency programs right now to help some of these needs. This is from the report. But next we're going to go to Samantha Greenberg. Welcome, Samantha.
Hi, thanks for having me. Similar to Carl, I don't know that I'm the expert in this, but I'm happy to share what I have. So, similar to Carl's site, we are based out of Kalispell, Montana, and a family medicine residency program. We are the rural-like training track. So our main site is in Missoula, Montana, which is about 2 hours south of where we are, which is for Montana, a more urban area. We are rural-like because the Flatt County, or Flatt Valley, which is the area that we serve, is about a population of 115,000, and that has been a pretty exponential growth over the last 10 years, even more so over the last 5 years and continuing. And so we are technically rural by federal standards, but definitely not rural for Montana standards. So our residents spend their first year down in Missoula and then come up to Kalispell for their second and third year. So we have 6 residents at any given time. And when our residents are here in Kalispell, they do all of their rotations up here. Residents that choose our site tend to want to be in a more rural training setting and sort of have a little bit more low volume, like low provider to resident ratio, a little bit more sort of independent and autonomous practice. It's just a little bit of a different feel than the larger academic practice down in Missoula. And similar to Carl's program, we started our program. This is going to be actually our 10th graduating class this year because in Montana, we knew that we were not graduating enough medical residents to provide primary care in our state. And at the time our residency started, there was only one other residency program in the entire state. Now there are a total of 5 residency programs in the entire state, soon to be 6. So we're definitely increasing the number of primary care providers that are graduating from Montana, and similarly have about a 50 to 60% retention rate of our graduates staying in Montana, but we still have a really long way to go. So we are a little bit different in that we are embedded within a pre-existing freestanding FQHC. The FQHC is not our residency, which is a little bit different organizational structure than a teaching health center, like in the Utah program with Carl. So there is a practice at Greater Valley Health Center that has their own providers, and then we are also part of that. And the residency is the home for all of our prenatal, delivery, and postnatal services. No other providers that are part of our clinic do prenatal care or delivery care. Other providers within our system do pediatric care, contraception, and primary care for all. We do sort of a disproportionate bulk of the pediatric and contraceptive care because we are doing also the prenatal care and delivery. So we have 6 residents, and we have 2 faculty who do obstetrics within our site. One of them does C-sections, that's me, and then our other faculty member is a non-operative OB. And we have backup in our community at our hospital from our OBGYNs as well as MFM. So, and occasionally actually our C&M group has provided some backup coverage when we've had big gaps, like someone is out on a medical leave or something like that, and we just need some additional backup support. We have some other family physicians that work in our community or at more outlying rural communities that will also occasionally take OB call for us. We're pretty low volume, so we are a higher population area for Montana, but we are pretty rich in labor and delivery resources. We have a hospital-based obstetrics group that is 5 obstetricians. We have a hospital-based midwifery group as well as a private practice midwifery group that deliver at my hospital. And then there's a technically critical access hospital, though like almost within line sight of our hospital, that does similar number of deliveries, that is staffed by one OBGYN and a private practice midwifery group. So we are low volume within the residency program, but the hospital itself is much higher volume. Next slide. So just sort of taking a little bit of a different approach to this, thinking about sort of what the challenges and opportunities are for a program like ours, and where we feel like our goals are. So, you know, we have, like I said, lots of providers in our area. And so that for our clinic leads to some low volume, and that can lead to difficulty maintaining skills. And it's something that I think a lot about for our graduates and for my colleagues who work at smaller critical access hospitals is, if we are serving a small population, how do you maintain the scope of your skills? You know, even if you're just the one or two people doing surgical obstetrics, for instance, or, you know, how frequently are you doing vacuums and things like that, that do require some repetition to maintain those skills. So that's a challenge that we definitely face. And then because we don't have a lot of obstetrics patients, we also therefore have some limited faculty for backup. And so, you know, low volume leads to not really having the need for higher number of faculty, but that also means you're on call an awful lot. And so I think just something to think about is the burnout that can occur, which is the same, again, very similar to what's, I think, probably occurring in many of our rural locations, right? There's only a couple of people who are on call, and that means they're on call all the time. And what happens if they're out? I think some opportunities, thinking about where family medicine really can position themselves to be competitive in a more competitive market for patients, is that as family physicians, not only can we provide this prenatal care that our obstetrics colleagues can provide, but we can provide this really sort of wraparound whole family unit care, which I think is desirable for a lot of our patients, that the same provider that delivers them is the same person that's going to round on their baby, who's going to take care of them in the office afterwards. And so that continuity of care, I think, can be really important for our patients, and something that is a value that we can offer that others can't. I think the other thing that's really nice about that too is we have a pretty high postpartum follow-up rate, because we are almost always seeing our own babies that we deliver. So even though nationally postpartum follow-up rates are quite low, ours are higher than that, because we're almost always seeing those babies, which inherently means we're also seeing the mom or the parent. And then something that we have thought a lot about is, how do we create programs that are going to attract patients, again, to continue to seek care with us when they have other options. And I think family medicine is really uniquely positioned to do some things that other providers can't do, specifically thinking about medication for opiate use disorder in pregnancy through Suboxone or Subutex is something that any provider of prenatal care can provide, but family medicine, we're doing this a lot already within our non-pregnant population. And so it's a really easy flex to be able to add that and be able to be sort of a co-located place for these patients. And patients that maybe were already seeking services and then find themselves pregnant can continue to see us. We are also, I think, better positioned to provide perinatal mental health services, because again, we're doing a lot of mental health within our clinics for non-pregnant patients. And so adding that particular area of expertise, there's lots of training available. And I think is something that we're uniquely positioned to excel in and to be able to provide for our patients. And then the addition of lactation medicine as well. Again, being able to see both the birthing parent and babies makes that a little bit easier. Anyone that has sort of extra interest in lactation medicine, an OBGYN, a pediatrician can also do lactation medicine. But again, being able to see that dyad all at once, or knowing that both of those patients are yours, I think reduces the barrier and makes that a little bit easier to integrate, and then can be something that either attracts patients or continues to get patients to see you. I also think, you know, being an FQHC, we have lower barriers of care to marginalized communities. And so that I hopefully sort of is something that allows patients to be able to more easily seek services and see us. So, you know, having co-located health care as well as substance use disorder treatment, behavioral health treatment, patient navigation services, if sites can have integrated ultrasound, especially if it can be on a sliding scale for patients who are uninsured, I think lowers cost of burden to to birthing patients and families. And then just in general, the advantage of FQHC for non-insured patients is the sliding scale fees. And so at the very least, the outpatient cost and usually actually the delivery cost is also a little bit less expensive. We can't necessarily help the hospital cost, but the provider costs we can. Next slide. So just thinking about like our sort of what is our position when we're talking about workforce training. Our goal as a residency program, we were created to train residents to go out and serve rural and underserved parts of Montana and maintain a broad scope of practice. And so because that's our mission, maintaining a really robust obstetrics experience for our residents, both is something that attracts residents here and hopefully and has led to us graduating people who statistically are more likely to provide OB than sort of general family medicine graduates, if you look at the entire nation. It's important that we continue to model family medicine doing OB, just like it is us to model many other things, because our graduates are more likely to do a type of practice that they've seen their attendings model. Because we're low volume, we're able to augment that for our residents at the very least, so they graduate with enough depth of experience to provide care in rural settings with delivering with our community OBs and CNMs. And so when our residents graduate from our program, they are competent to provide low-risk prenatal care and deliveries, neonatal resuscitation, and then are also competitive to apply to fellowship if they so desire, if they want additional surgical training. But again, thinking about what are these challenges for even the residents we're attracting is while I hopefully am training many people to go out and provide obstetrics, we are running into the problem that fewer jobs in our rural communities offer obstetrics as a service line. And so the places where my graduates can get jobs and continue to provide this full scope of care can be more limited. And so finding a job actually can be pretty hard, we have found. And then similar to what we just talked about, if I send a non-surgically trained resident out to a community, are they going to have backup? Does that exist? Or are they not going to be able to get a job because they're not surgically trained? And then how do we maintain those skills in a low volume setting? And how do we balance the higher likelihood of burnout in someone who's going to be a high burden of call in a rural area? In particular, I think we're noticing that graduates from family medicine residency, just like everywhere, really are more prioritizing sort of that work-life balance is not the right word because it's never balanced, but like how do we continue to push this as something that people want to do? So I think that is all that I have.
Fantastic. Thank you, Dr. Greenberg. I'm monitoring the chat. We have from Becky here, we attempted to incorporate nurse practitioner, nurse midwife for about 8 months, but due to limited FTE needs and scope, we're unable to sustain the model. Since then, we've been able to increase our OBGYN staffing. And you bring up the great topic of the non-surgical backup. How do we address these gaps? So things to keep in mind. I'll invite all our participants to keep adding your questions in the chat for our panelists, and we'll attend to those. And I'm going to now turn it over to and welcome Tanya Beatty from North Dakota. Tanya.
Hi, thank you so much. I have a lot less in terms of introductory slides here, but I'll just tell you a little bit about our practice. So family healthcare is in Fargo. We're way, way, way out on the east side of North Dakota. We serve people from eastern North Dakota and western Minnesota as well. Similar to what Dr. Whitaker was talking about, I think our patient population looks very similar as far as makeup. We have a lot of immigrants and refugees. The vast majority of patients that I see in any given week were not born in the United States. Many of them are using interpreters. Our payers are mostly Medicaid and sliding fee, and we have we do have some other programs too. Besides refugee health, we have like a homeless health clinic. We are the provider for the local jail. All of their pregnant patients are our patients as long as they're incarcerated. we right now there's two of us midwives. We had a third, and similar to what Dr. Greenberg was talking about, when you have a small practice, you're spending a lot of your time working, and so the third one unfortunately decided that she was she'd reached a level of burnout where she couldn't continue with us. So there's two of us. We have full scope midwifery. So we're doing all of our prenatal care, postpartum, birth control. We're putting in Nexplanons, IUDs. We do well women care. We've both had extra training in colposcopy so that we can offer that service to our patients. And we see our newborns for the first 28 days, we can also see them in the clinic. So we are doing a lot of that mom-baby postpartum care together for that first. We have all of our moms scheduled at 2 weeks for their first postpartum checkup along with their infant. And a lot of times we're seeing them even sooner if we have a mom needing a blood pressure check along with babies, like 3 to 5 day weight check. We do those visits. And we do a lot of well women primary care. I have many patients who are coming to me for their mental health, their thyroid needs, as well as, even those who aren't pregnant. We also prescribe Suboxone medication for opioid use disorder for pregnant patients. And then a lot of them, when they're no longer pregnant, they continue to see us for that. So our backup is Sanford. We have, they have a good team of OBGYNs, and their maternal fetal medicine doctors in particular are wonderfully supportive of us. We couldn't do what we do without them. One of the biggest challenges that we're seeing right now is that it seems like a very, very high percentage of our pregnant patients fall into a high risk category. And historically, when you think about midwives, you're thinking about low risk pregnancies, low risk births. And if there are low risk pregnant people out there, I don't know where they are. I don't see them. Everybody seems like they've got some risk factor or another. We have a lot of chronic hypertension and pre-existing type 2 diabetes, a lot of mental health, so the way that we manage those pregnancies, given the midwifery scope, is through collaboration and co-management. We've basically set it up so all of our pregnant patients just go to maternal fetal medicine for their 20-week ultrasound, with very few exceptions. And then they have the opportunity to get to know them and then to continue to see them for more visits if needed. The other big challenge that we see really is the staffing and recruiting, which was mentioned before. We've had in the last several years 3 or 4 other candidates that we have made offers to, midwives who have initially looked like maybe they were going to come work with us and then backed out at the last minute, taken other jobs elsewhere. Fargo is cold and snowy and kind of nasty in the winter, and FQHCs don't pay, as we can't always compete with other bigger health systems. So trying to get one thing that I've been doing recently is trying to spend time talking to the labor and delivery nurses that I'm already working with about going back to school and getting their midwifery degrees. People who are already here in the community, they're the ones who are going to make it so I can retire someday. We're hiring from Fargo is a community that is very largely made up of transplants. It seems like 2 out of every 3 people I talk to were born somewhere else and moved here, but that's not. It's still really hard to get people to want to come and do this work in not the most exciting city in the country. So, we're not the only one who's having that challenge. The hospital where we have privileges, they have a midwifery program. They've had a really hard time retaining midwives, and that's partly due to some conflicts that have happened historically between their midwives and their OBGYNs. So right now they have 3 midwives and we have 2, and that neither of those is enough people to really create a good on-call rotation. But when we started sitting down and doing the math, we realized that 5 is actually a pretty good number. So what we're working on at this moment is actually building a shared call model between the 2 of us and the 3 of them, so that I can be on call 1/5 of my life instead of half of my life. That's I don't know what I'm going to do with myself. I think that's going to be pretty glorious. Um, there's plenty of other things that we would like to be able to do. We would love to be able to do group prenatal care, centering pregnancy. We would love to be able to do more teaching. But the reality of it is that we have to be able to just cover the very basics of, having someone on call for a delivery and taking care of ourselves and being present in the clinic. One person can't be in 2 places at once. For a long time, we were doing, on call, still coming into the clinic and scheduling patients, and it was too busy. We didn't have enough staff to do that. So now, then, in order to be in the hospital more, we have to be in the clinic less, and that creates barriers for access. So, the best solution that we have in front of us is really just to increase that collaboration with that partnership with the hospital midwives. I did include some statistics here for our practice. We're busy. There's a fair percentage of our patients that get delivered by Sanford providers, either C-section patients, or there are some that are transferred just in labor for high risk, like our patients with suspected fetal growth restriction. Those are ones that we generally see throughout the pregnancy, but then the OBGYNs take those over for delivery. They also do our VBACs. They haven't given us those privileges, no matter how many times we ask. But we are still doing a large number of our own births. So in 2025, essentially between the 2 of us, we delivered 112 babies. And that's a lot. We spend a lot of time up at the hospital. We round postpartum on our own moms. We were rounding on our newborns as well. We've kind of backed off of that because the midwives that we're looking at partnering at don't do that. And so it doesn't really make sense for us to do it, but for them not to, if we're going to be sharing time together. But we have good outcomes, even with very high risk patients, and midwifery care, as opposed to having OBGYNs as their primary care providers. We have statistics that are as good or better than the national and state averages. We're very proud of that. We build really good relationships with our patients. I have patients who are now coming back to me. I've been doing this 8 years, and I have patients now that I'm seeing for, maybe their 4th pregnancy in that amount of time. So that's generally how patients find us. They've come to us because they need us, because they don't have insurance sometimes, or because they came through as refugees. They started out seeing our as in our refugee health program, and then were transitioned to us because when they got pregnant. But also then in the community, family and friends, they hear about us. They're happy with the work that we provided for their loved one, and so they choose to come see us too. Fargo has 2 big health systems. We have Sanford and Essentia, so most patients could choose to go there if they wanted to, but we do have people, even people with private insurance, who still choose to come see us because we do good work, and we're well respected in the community. Mm-hmm.
Tanya, thank you for sharing that with us. Super excited to learn about the good work you're doing in Fargo. I'm going to invite all of our panelists back. Maybe you can take yourselves off mute, but what I'd like to do is have our first portion of our discussion focused on workforce issues. You can see some of our questions here. We don't have to go through all of them, but basically, as you've all alluded to or spoken directly about, We've got workforce shortages in a lot of different places. Um, so I'd like to invite our panelists to see, you know, particularly in rural and underserved area, what creative strategies have you used or seen on the recruitment and retention side of things?
I'm happy to start with this. So in the chat, someone had asked about retention, and I said, our site, we actually don't have a great retention rate. That's purposeful though. So the mission of our program is to train people to be in rural and underserved Montana, and we don't particularly consider ourselves rural. So we are hoping that we are recruiting, and we are really conscientious of this when we're doing our resident recruiting, people who are going to want to be more rural than us. So our goal is that they leave us, but that they feel prepared to go into these more rural and frontier communities. So I think that is one strategy, is being very intentional about our recruitment for residents, that they are interested in providing that full scope and being in a more rural area. And we have lots of different metrics that we use to help us assess that. The other thing that we do is most people train near the place or stay near the place that they train. And so we have a rural network of 17 sites throughout Western and Central Montana, and residents are required to do 2.5 months at one or more rural sites throughout their 3 years of residency, to do to get experience in those communities. And so many of those communities then benefit from our residents working with them. So there's retention within that system. So getting a little bit of that experience out from the main place to see what it would be like to practice more like a full spectrum rural doctor, because if you've never experienced it, the likelihood that that's something you're going to want to do and stay in a community is probably lower. And that's been pretty successful.
Great, thank you for that. Any other comments from Tanya or Carl on workforce recruitment?
Yeah, I mean, part of our grant was to try to figure out how could we increase that pipeline, because it's always it seems to be a struggle to get people to want to go rural if they don't already have that in their blood, if you will, or in their intention. And so I think Dr. Greenberg's exactly right in the sense that trying to recruit people who have that interest already, I think is one aspect. Um, we have our fellows. Our residents will do this too, coming up in year 2, but our fellows do at least 2 weeks in rural, which isn't much, but part of the reason they're here is for volume and to get the C-section skills. And sometimes going rural is hard because they can do 0 to 2 C-sections in those 2 to 4 weeks. But we have a really great partner in Casey McCullough in Blanding, Utah. So they get to go see what someone looks like that they would do their job, right? He does all the things that they would do. And so that helps in that sense. It has been a struggle, I would say, when we initially tried to get preceptors. I think preceptorship is becoming a struggle for us, because even graduates of our program that go rural, they ask their partners aren't interested. Teaching it's a significant time investment for people, and one of the partners we tried to partner with, I thought was a really great fit, and they wanted to know what was in it for them. And they said that we get slowed down. We can't, I mean, I think to Tanya's point was we're just trying to stay afloat and seeing the patients that we can see. When you add other mixes in there, like teaching, if you're going to do it right, it takes time and effort. And I think preceptorship is becoming more of a struggle at least for fellowship. I think for residency a little bit too. Um, but we have to have people who are mentors and models of this. And so, um, I think that's another wrinkle to figure out with how do we get that. I will say that we had an applicant last night from rural Utah for our residency, and he said that he never even thought about it until someone came to his high school class. And so I think we've been looking at that, right? Like we need to start introducing people that are from rural areas to healthcare, with the hope that it's a long game, right? You hope that you say something there that will they'll be coming back to those areas. And Dr. Howard always mentions this, but one of the factors in getting people to rural often is if they're from those areas, or if they have a partner that's that's from those areas, because those are things that there are certain things that come with living in rural areas. So I don't have the answer, but I'm not sure what we've done is always what we need to do. I think there's some innovation there that we need to figure out. I think there's a program called Our Moms, Rural Maternity and Obstetrics Management Strategies. It was a grant we applied for. We did really well, but there were other states that had higher need. But I think you can do that outside of HRSA. But the idea was, we would have our residents and trainees go into rural areas. But the other thing was having the opportunity for those in rural areas to come to a tertiary center to get volume where they can keep those skills up because I think Dr. Greenberg alluded to this, like, you go out into rural practice and if you don't deliver very frequently, you may not be competent in that area. And so this idea of like there needs to be a little bit of like a two-way street. And I think we need to listen to our rural partners better. Um, they can tell us what they need. I think sometimes from a university setting or an academic setting, we think we have the answers. We kind of go in, and I don't think that's the right way to go about it. And I think that we really need to see what our rural partners want. Um, but I think maybe a two-way street where they can get some additional training would be helpful. And then building that pipeline.
Great. Thank you, Dr. Whitaker. On that note, a big shout out to AHEC, which helps with Rural Pipeline, getting people out into high schools to talk about health careers. I love what Tanya's strategy around recruiting from within to get people into midwifery. And I'm going to skip over the next slide, one slide with regard to time, but just closing question. We're a little bit over time, but have one quick minute. If you could do one thing tomorrow, what would it be? I want to hear one quick takeaway from each of our panelists. That's that one thing you'd do tomorrow if you could, if you had a magic wand. Where should we invest? Where can we get the greatest leverage? Where to invest?
Um, you know, for me, this would definitely be like more midwives in our community. There's certainly opportunity as well in getting like doulas or community health workers or social work case management. But but having some more midwives and then the amount of time that we get to spend with our patients, if we can spread out um, throughout the day, like just spending more quality time with our patients, having a reimbursement model that really allows for that, so that we're not trying to rush to see as many people as we possibly can with as few staff as possible. Because right now that's the situation that I think everyone finds themselves in, is it's all about volume. It's all about, productivity and numbers. And that's not what makes a difference in patients' lives. What really makes a difference is that quality time that they get to spend with a provider. And, whether that's a doula or a midwife or their family practice doctor, when you're doing 15, 20-minute visits, you know, because you don't have enough access, you don't have enough providers, or because that's the only way you can keep the lights on, the quality then really suffers. So to have a adequate workforce and then adequate reimbursement to allow us to really invest in just spending the time that our patients need, that would be absolutely number one on my list.
Great. And a topic that came up in our last session with public health and primary care coordination is advocacy for reimbursement for integrated care. Quick lightning quote from Carl or Samantha as
I'll
we
just
close.
say funding, teaching, pipeline, anything along those. I mean, I think funding is a big, huge issue, obviously, with this. And I think it comes back. I think we need to look to our rural partners to tell us what they need, because I think that they have the ideas that will actually help solve this. And I think it's easy for us to kind of sit in my position. I'll speak for myself. Not being in a rural area, I think rural is a big deal. I think that's where we need to put the time and money and effort, in my opinion.
And I would say, similar to what Dr. Whitaker had said before about like options for people who are in a rural area to train, like to go back and get some volume increase. I actually don't feel like I have a huge problem getting people to those communities. The problem is staying in those communities and continuing to provide obstetrics under the challenges that we just talked about. And so what kind of support services or can we have to make sure people retain their skills and want to continue to do this despite the fact that there are these pressures that make it hard for them to do this care? So is it having, in a state like Montana, which is pretty small, we all kind of all know each other, like, is there some sort of community that we can have where people can bounce cases off of each other? Is there some sort of exchange where people can go for higher volume? Is there someone who can do telehealth and has an expertise in perinatal mental health or substance use disorder and pregnancy that patients can see when they're in Butte, but they don't have that expertise there, so that patient can stay within their community and birth? Like, we are a mighty force. We just need to figure out how to connect each other and support each other to stay in this role.
Fantastic. Thank you. And on that wise note, I want to thank you all for joining us. Thank you for sharing your wisdom. I have a lot to take away from this. Thank you so, so much. And if you're able to stick around for our next session, our closing keynote, Danelle Pendergrass from here to give us some uplifting insights to action about maternal health. So again, thank you for joining. And if you can hang out for the next session, we'll see you there.
Excellent. Thanks so much. I'd like to thank Dr. Talboys, Whitaker Greenberg, and our fantastic midwife, Tanya, for sharing their expertise with us. We're going to ask for your opinions in a very brief survey that you can find in the chat. Please take just a couple of moments to complete that now. If you're leaving us for this session, thank you so much for coming and participating. And if you're staying on for the closing keynote from Insights to Action, you can stay logged on. We'll be moving you to the Zoom waiting room while we set up for the next session, and we'll bring you back at the top of the hour. So thanks again. I hope to see you all shortly.